and welcome to our sixth lecture. We're going to be covering two distinct types of disorders in this lecture. We're going to talk about somatic symptom and related disorders, and we're also going to talk about dissociative disorders at the end of the lecture. So let's just generally think, what are the questions we want to answer with this chapter? We want to talk about the features of each of these different types of disorders. Where do we think they come from, and how are they treated? We're kind of transitioning pretty dramatically from our previous chapter on anxiety disorders. As you know from the lecture and from your textbook, anxiety disorders are up there with depression, perhaps the most common type of disorder that you're likely to experience throughout your life. They have much higher prevalence rates than others. The disorders we're going to discuss today tend to be quite rare. And I think as a result, it's sometimes difficult for us to relate to and understand these disorders as compared to, say, anxiety or sadness, all of which are sort of part of most people's normal spectrum of emotions. So I'm going to do my best to give you a good sense of what it's like for individuals that are dealing with these disorders, what they look like when they manifest themselves, and hopefully some of the things we can do to try and help people to improve their quality of life and reduce their distress. So we're going to talk about the major disorders that are covered in the chapter in the DSM-5 under somatic symptom and related. So that includes somatic symptom disorder, illness anxiety disorder, psychological factors affecting medical condition, which is more of a diagnosis than an actual disorder per se, and conversion disorder. And then we'll move on towards the end of this lecture and talk about dissociative disorders. And those include depersonalization, derealization disorder, which we will define and hopefully make very clear, dissociative amnesias of various types, and then dissociative identity disorder, one of the rarest and most controversial diagnoses within the whole DSM. So when we use the term somatic, what do we mean? Somatic generally refers to a physiological symptom. And what we typically think of when something becomes a somatic symptom disorder is when there are excessive or maladaptive responses to physical symptoms or health concerns. So the word soma literally comes from the Latin for the word body. It's essentially a preoccupation or an obsession with your health or symptoms. And I use the word obsession very loosely in this context, but I do think there's something interesting about the overlap between, say, aspects of obsessive compulsive disorder and the various somatic disorders. These are things that the person becomes overly preoccupied with, has a lot of difficulty disconnecting from, and that starts to cause them distress because it looms so large in their consciousness and in the way they think that it becomes the focus of their attention to the detriment of other things. Invariably in these types of disorders, you're going to hear some sort of physical complaint from the patient. They're going to often present to medical providers' offices, emergency rooms, long before they see a psychologist or another mental health professional. And there's usually no underlying identifiable medical condition, which leads those people to then often seek mental health treatment. But that can be a very painful and difficult process for a lot of patients to be told this thing that you genuinely believe you are experiencing in most situations, most of these disorders, is in fact, quote unquote, all in your head, right? No one wants to hear that. It can be very frustrating because the experience of the symptoms is legitimate, and things like pain and disability are very real to these individuals, despite there being evidence that there is a psychological cause for some of them. So that process of identifying and diagnosing these somatic symptom disorders is actually quite difficult because people do not seek out mental health care initially, at least, and oftentimes they go through an exhaustive process of potential diagnoses and ruling things out before there is a reference to a referral to a mental health provider. So in the previous iterations of the DSM, prior to DSM-5, these were called somatoform disorders. And there have been some changes in DSM-5, some refinements and some alterations in terminology. So if you hear the term somatoform disorders, it's a reference to just what these were called previously. Another thing to think about is we've discussed body dysmorphic disorder under the sort of obsessive compulsive disorders heading. It was previously classified as a somatoform or somatic symptom disorder because it involved concerns about the body. It's now reclassified under that sort of OCD and related disorders chapter because of its obsessive and compulsive nature. So things like excessive, unrealistic focus on certain features, compulsive actions like checking yourself in the mirror, or efforts to conceal a feature that's being distorted by the mind. And it has a very similar response, body dysmorphic disorder does, to the treatments that are used for OCD. So this is a good example of the iterative process we go through in science and in classification and taxonomy, like the DSM-5, that a disorder that was previously in a different chapter is moved, and that does happen. Or you see things like we've seen with the trauma-related disorders, where an entirely new chapter is created because there's sufficient evidence to say perhaps something like PTSD does not fit perfectly into the anxiety disorders heading. So there's a lot of change that happens, but ultimately these are all things that relate to physical complaints that arguably have a psychological cause. There are, as I said, there are 4 different areas we're going to talk about in this chapter of the DSM-5. Three disorders, quote unquote, and one that I think is more of a diagnosis than a disorder itself. So we're going to talk about somatic symptom disorder, illness anxiety disorder, which is a change in terminology from previous iterations of the DSM. We'll talk about that when we come to it. And as I said, psychological factors that are affecting a medical condition. This is when there is an underlying real physiological illness, but the psychology of the individual is having a negative impact on how that condition is experienced, managed, or treated. And then conversion disorder we'll also talk about. So somatic symptoms, or somatoform disorders as they were called at the time, were first identified by a French doctor whose last name was Briquet, and he noticed that patients were coming to him with numerous complaints who had no medical basis. And so he became interested in this idea of perhaps the underlying cause of these complaints, these ailments, is in fact psychological rather than physiological. So it was formerly called Briquet's syndrome. There is a larger group of disorders, and so I think this can be a little confusing. When I say somatic symptom disorder, we've also said these are called the somatic symptom and related disorders. So the terminology is slightly confusing. Just be careful of that distinction, that we will use the term somatic symptom and related disorders as the overarching heading, but now we're going to talk specifically about the diagnosis somatic symptom disorder. This was originally called somatization disorder, again, just to make things a little more confusing, in the previous DSM. And what happened with the original diagnosis as it was established, not the original, but the most recent diagnosis prior to the DSM-5, in the DSM-4, it necessitated a large constellation of different types of symptoms to be present. So to be diagnosed with somatization disorder, as it was known, you had to have multiple complaints of various types of symptoms. So they've reorganized this classification within DSM-5. You can have only one symptom now and still be diagnosed with a somatic symptom disorder. That's a good example of what happens sometimes when things go out into the world and classification systems and they start getting used by actual providers. Is sometimes what you'll find is, I have this person who's in my office, they're presenting with distress, they're showing impairment in their functioning, but they're not meeting all of the necessary criteria for what feels like the appropriate diagnosis based on presentation. So one of the iterational changes that happened was the idea that requiring the person to have, say, 4 of 8 of these constellation of physical symptoms was creating a situation with lots of patients who had subsyndromal diagnoses. Perhaps they present with 1 or 2 or 3 symptoms and don't meet that threshold, but clearly still suffering from something that's causing them problems. So as a result, there was a change that was made in DSM-5 to allow for only one disorder. There is some confusion sometimes distinguishing somatic symptom disorder from illness anxiety disorder. And again, the names are very general, and I understand that can be confusing. Both of them can involve anxiety about physical health. In illness anxiety disorder, though, the symptoms are typically mild or absent, meaning the person believes they have a serious physical illness, but they are not really presenting with the actual symptoms that much. The main problem is the high level of worry or anxiety about having that said serious illness. For example, someone who is convinced that they have cancer despite any real evidence to that effect. They're not losing weight. They're not necessarily, showing other signs of cancer based on, laboratory markers from blood draws or from imaging like MRIs and CT scans. They're not presenting with the actual symptoms, but they have a strong belief that they have the disorder. That is more commonly seen in illness anxiety disorder, which we're going to talk about next. What's different in somatic symptom disorder is that the symptoms are definitively present. Okay. The main problem is the preoccupation with the symptoms themselves. So, for example, always researching the symptoms online, constantly talking about these symptoms to friends, family, and medical providers, complaining about the physical symptoms to anyone that will listen in many cases. It's not a concern that the symptoms are indicative of a serious illness, although this may be part of what's going on. But in somatic symptom disorder, there are manifest symptoms, whereas in the illness anxiety disorder, the concern is about having a serious illness, in many cases in the absence of any real identifiable symptoms. So as far as the actual things we start looking for to classify something as somatic symptom disorder, you have to have one or more somatic or physiological symptoms. You can think of the word somatic as being synonymous with physiological, and that symptom is often medically unexplained. Now, this is where this process of being properly diagnosed and obtaining treatment can be very difficult and tedious and expensive in a variety of ways for the individual. So if you think about a lot of vague symptoms that we can have. For example, pain, headaches, stomach upset, mild dizziness or lightheadedness. These are all things that can have a whole host of causes. And if you're a physician or another medical provider and someone comes to you with a symptom like headache, there are hundreds of things that can cause a headache. If someone comes to you with pain, you can start to ask specific questions even before you've done any imaging or anything and try to rule out what type of pain it is. But even then, the possible etiology or cause of that pain is wide and diverse. There's lots of different things. So when you hear this concept from medicine of differential diagnosis, what are all the different things this could be? You can begin to understand how someone with somatic symptom disorder who is presenting with real symptoms that they are describing could go through an extremely exhaustive, tedious, and expensive process of getting to the point of the symptom being quote unquote medically unexplained. And that can really be the thing that puts a great deal of stress and cost on the individual, but also on the medical system. It can be very frustrating for medical providers, for patients that are presenting with these types of disorders. So it is characterized by those excessive, those out of proportion thoughts, feelings, and behaviors related to the symptoms. Excessive thoughts about how serious they are, frequent complaints and requests for help, a lot of health-related anxiety, and excessive research. Now, the internet has amplified this last symptom beyond belief. There's a lot of frustration, even with people without a somatic disorder. There's a lot of frustration with medical providers when people come in who have done extensive deep Googling and they've decided what they have and they know what kind of treatment they need. We're seeing examples of this right now with things like ivermectin and hydrochloroquine, where there's no medical evidence, but the person has done extensive research. And I'm putting research in quotes here because it's not actually good research, because it's coming to false conclusions. And it's not based on good empirical science. Nevertheless, the internet and the accessibility of information, full stop. I'm not talking about the quality of the information or the reliability or credibility of the sources, but simply the ability to just search and delve is so easy and so exhaustive on the internet now that it's really had a huge negative impact on people with these types of disorders, because it's endless, the amount of time you can spend searching and Googling, what's going on with this symptom that I'm having. It used to be at the very least you would have to, go to a medical library, read journals, that kind of thing. But the online access has just made it all that much easier to feed into this excessive fixation on the symptoms. And then, as is always the case, it reaches a point, it's significant enough that it leads to substantial impairment in the person's social or occupational functioning. So social functioning could be to the extent that because the person is constantly complaining about this physical symptom, they start to distance themselves from people. People want to spend less time around them. Another concern is occupational functioning, overuse of sick days, showing up late, not showing up for work. When you are at work, having to leave early because of the symptom. So it can really have a significant impact on people. And you'll often see a lot of people who have this type of disorder who have found themselves unable to work because of the symptom, and in many cases may have even been approved for various forms of disability despite, any real underlying illness, because of just how persistent the complaint of the symptom is. There are some examples that are kind of rare within rare that I want you to think about too, is that sometimes the symptoms are explained by a known medical condition, but the person's reaction to them is extremely excessive. So there might be some very mild discomfort or pain or otherwise, disability that the person is just amplifying and obsessively focusing on. So there are some situations where there is an actual underlying illness that's causing the somatic symptom, but it's just being responded to in an inappropriate fashion. These are the actual DSM-5 criteria for somatic symptom disorders. So I said one or more somatic symptoms that are distressing and result in significant disruption of daily life. Excessive thoughts, feelings, and behaviors related to those somatic symptoms or the associated health concerns. And that's manifested in terms of disproportionate, that's a really key word here, excessive, disproportionate, and persistent thoughts about the seriousness of the symptoms. High levels of health-related anxiety. There's a reason why this chapter follows the chapter on anxiety disorders, because there is some overlap in the underlying emotional state, which is worry or anxiety. And then, as I mentioned, excessive time and energy devoted to these symptoms and related health concerns. And while this symptom is not, it doesn't have to be continuously present, the state of being symptomatic is persistent, typically about 6 months. What this means is that the symptom itself, while it may, wax and wane and fluctuate, it needs to be persistent. It needs to be largely present over the course of a significant period of time. And what you're looking at here is you don't want to diagnose someone in the very early stages of something when it could be something else. You're trying to really show this is a chronic issue. It's persistent. There are some specifiers that you would make if you were diagnosing an individual with this disorder. You would specify with predominant pain, which we used to call pain disorder in the DSM-4. This is for people that have their somatic complaint is primarily pain, which is a big subtype of this disorder. You have to talk about the degree of severity, mild versus moderate versus severe. And this is just a way of qualifying and sort of placing this disorder in a context that other providers have a general sense of how much impairment this is causing the person. This is all, of course, taken from the DSM-5. So as I mentioned on the outset, these disorders, and specifically the somatic symptom disorder, are very rare, relatively rare as the way your book puts it, but I would say significantly rare. The onset usually occurs in adolescence. People will often start, having these physiological complaints relatively early in life. It is just demographically, statistically speaking, it is more likely to affect those that are unmarried. It's more likely to affect women, and it's more likely to affect people of low socioeconomic status. There's kind of a fascinating aside of sociology that's unique to our current situation in the United States and in other places, but it's really prominent in the United States, which is lack of access to affordable quality health care. So you can imagine that people that have excellent health care or good financial resources, that is high socioeconomic status, are able to seek out a lot of diagnosis and treatment and have good access to medical providers who can rule out the fact that this is a serious symptom. Many people are just living in fear that the symptom is worse than it is, or amplifying it because they fear, in addition, I'm not going to be able to get access to and or afford the medical care that I need. So there's a sociological underpinning to some of this that you can imagine plays a role. And somatic symptom disorder tends to have a chronic course as opposed to an acute course. So when we talk about disorders in general, if you remember, one descriptor is chronic versus acute. Is it something that comes on quickly and potentially resolves, or is it something that tends to have a relatively slow onset or an insidious onset, as they say, and then becomes a chronic issue for that person over the course of a long period of time, often years? Research is limited on these disorders by virtue of them being rare. So anytime you're talking about a rare disorder, unfortunately, what that means is we often know less about it. There are less resources allocated to researching it. So if you think about the sociological and cultural impact of things like depression and anxiety and what that means in terms of costs and concern and how prevalent and widespread it is, how it affects a lot of people, that puts a lot of light on those disorders, and therefore a lot of funding, a lot of attention is paid to the cost to the individual and society as a whole. When you're dealing with something that has a low prevalence and is relatively rare, as a result, what happens is you don't get a ton of research done on it. I can give you sort of an analog in the medical world, which is ALS. Now, many people I can always mispronounce this, amyotrophic lateral sclerosis, also called Lou Gehrig's disease. Many people were entirely unaware of ALS, if not only vaguely aware of it, prior to the Ice Bucket Challenge, which was a very popular viral thing that happened a few years ago. And as a result of the Ice Bucket Challenge, there wasn't a significant amount of money raised to do research on ALS. Part of that that social outreach program that was that Ice Bucket Challenge was, hey, this is a horrible condition that affects very few people in the grand scheme of things, but it is so awful, we need to figure out if there's a possibility of curing this thing or treating it more effectively. And so it was an attempt through that sort of very popular craze of, having celebrities and famous people be willing to undergo this Ice Bucket Challenge and to raise awareness to get more funding. But that often happens, that rare disorders have to have sort of a vanguard or someone who's, high status, high profile, who's out there really, informing people about it and getting some attention paid to it. Otherwise, not a lot of research is done. So as a result, we know that it's relatively rare. In addition, there was a pretty big shakeup between DSM-4 and DSM-5 in how a lot of these things were redefined and respecified. So if the name is just changed, then there will be research on the condition. The name is just changed. That's all there is to it. But in fact, the actual criteria changed significantly, and some things were incorporated into others, and some things were sort of split. And so as a result, there's not a ton of research on these specific disorders because, in a sense, under this heading, they're relatively new. And under these particular criteria, they're relatively new. So that also affects the amount of research available, is that we haven't been talking about these disorders under these headings for very long. I want to move on now and talk about illness anxiety disorder. This is the one that I think you probably know colloquially as someone being a hypochondriac. What we used to call hypochondriasis in the DSM-4. So hypochondriasis is simply is the noun of the illness or the disease, the disorder, whatever you want to call it, and hypochondriac is an adjective to describe a person. But ultimately, if someone says I'm a hypochondriac, we all have a general sense usually of what that means. An understanding that someone thinks they're sick when they're not is essentially the connotation of that term, hypochondriasis. So clinically, what we're talking about with illness anxiety disorder is someone who has severe anxiety about the possibility of having or acquiring a serious disease. The actual symptoms are sometimes quite mild or even just absent, right? So as I said, that's an important distinction between the somatic symptom disorder and illness anxiety disorder. So in many cases, the person has only mild manifestations, if any, of actual symptoms, but there's an extreme amount of anxiety about having that illness nonetheless. The person is convinced to a degree that borders on delusional, we might say, that they have this illness. And no matter what the reassurance or the evidence or the imaging or the testing they receive from medical providers, they will often remain convinced, nevertheless, that they have the illness. As you can imagine, this is deeply frustrating for medical providers. Normally, if you're a physician and someone says, I think I have cancer, and you're able to say, actually, no, based on the evidence, you don't have cancer, that's a great thing. But when the person says, no, 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 I don't care what you say, I still have cancer, you can understand how that would become very frustrating and also eats up a lot of time, energy, and resources in the medical field. So this is not something that you can simply explain to the person and have them be disabused of this notion. In fact, a lot of times what they'll do is just double down. And so when the person says, look, the imaging doesn't show it, well, that's because I must be in its early stages. Or they'll start to make explanations to rationalize why they still have the illness. As I mentioned a little bit at the beginning of this lecture, I think this starts to touch on what can be difficult to fully grasp about these two classes of disorder we're talking about in this lecture is, and this may be true of OCD as well for people that don't have obsessive compulsive disorder, it's kind of difficult to imagine what this feels like, because while there is an argument that this exists on a dimension and on a spectrum, on a continuum, that we all have some degree of this, this is really, for many people, a bridge too far to their understanding. We might look at someone who is convinced they have cancer despite medical evidence to that fact and think, why would you think that? What would be the motivation, or what would be the reason to feel that way? It feels very irrational to most of us, and so I think it's hard to get a handle on it. And the same is especially true of medical providers that are treating it, because they're saying, look, I'm utilizing the science and the evidence to the best of my ability, and I'm telling you, you don't have this thing, and yet you have a patient who insists they do. Sorry for the small font here, but these are the actual DSM-5 criteria. So as I said, the first criterion and the most important is this preoccupation with fears of having or acquiring a serious illness. In many cases, there are no somatic symptoms present, or if they are, they're very mild in intensity. If another medical condition is present, or there's a high risk for developing a medical condition, the preoccupation is clearly excessive or disproportionate. So as I said, either the condition's there, but it's not very serious. But in some cases, let's think about someone who has an illness that runs in their family, whether it's cancer, heart attacks, heart disease. The person might have, that might be the trigger, that might be the inciting incident for a belief that they have this thing despite evidence. As I said, high level of anxiety about the health, and the person is easily alarmed about their personal health status. So they have a high emotional arousal in a negative sense to anything that relates to them being sick or having this illness. The individual tends to perform excessive behaviors as a result of this, repeatedly checking their body for signs of illness. There's examples of people who are convinced, like for example, males that are convinced they have testicular cancer, that are doing lots of self-exams, and then similarly, women that are convinced that they have breast cancer despite any evidence thereof, who are constantly checking. People who are worried about skin cancers might be like sort of focusing with a microscope or a magnifying lens, on their skin to great detail, looking for something that they believe is there. And then they may have, in an interesting way, exhibit maladaptive avoidance. They may be convinced they have an illness, and they're going to be told they have that illness, and therefore they avoid doctor's appointments in hospitals. So there's different manifestations of this. It has to be present for at least 6 months. Again, we want to say that this is a persistent issue and not just something acute that's going on. The actual illness that is feared may change or adjust over that period of time. The reason being, it's sort of part of the rationalization process. The physician might say, you don't have this type of cancer. Well, I know maybe I don't have that type of cancer, but I have another type. Or, well, if it's not cancer, then it's this. It's not better explained by another mental disorder like somatic symptom disorder, generalized anxiety, or OCD, because sometimes OCD can sort of blur the lines a little bit, where the obsessions are about themselves or someone they care about dying, developing a horrible illness. As we said, there's kind of a distinction between the care-seeking versus the care-avoidant type. So this is something that you want to specify within your diagnosis, because those are very different manifestations of the problem. There's those that may overly seek care and exhaustively seek care, undergoing a lot of tests and procedures, sometimes unnecessary, potentially harmful procedures, if the provider will agree to it. And then there's the care avoidant type, which is people that avoid seeing doctors, going to the hospital. Um, so in the transition from hypochondriasis in the DSM-4 to illness anxiety disorder, things were made a little more tight, a little more narrow in what constituted a disorder. Now, this is likely due to research by the committees that were building the DSM-5 saying that the threshold for hypochondriasis is too low. It's too easy to diagnose someone. And perhaps what we're doing is we're muddying the waters. We're lumping people together who have different degrees of severity of this dimensional condition. So it's actually even rarer to meet the criterion set down in the DSM-5 for illness anxiety disorder than it was the criteria that were set down in DSM-4 for hypochondriasis. So 20% of patients who used to meet that larger hypochondriasis diagnosis now meet the modern DSM-5 criteria for this disorder. It tends to have, when it's severe, it tends to have a later age of onset. And this is probably because it's more likely to have physical problems as you get older, right? It's more, at least superficially on the surface, it is more rational to be concerned about a heart attack, a stroke, that sort of thing, or cancers. As I mentioned, there is often some overlap and some comorbidity with anxiety and mood disorders as well. There is an interesting idea behind this that says that for some people, when they are suffering psychologically, they view it in those terms. They abstract it to their thoughts, their feelings, their emotions, these more abstract kind of subjective things. For others that don't have that vocabulary or are uncomfortable with talking about thoughts, emotions, and feelings, and that could be due to the individual, it could be due to the way they were raised, it could be cultural, they tend to somaticize their symptoms. And this is a phenomenon that I've definitely seen with patients, which is a patient, for example, who is more depressed and more anxious, who is making more physical complaints than talking about the fact that they're more depressed and anxious. They might be reporting that their pain is worse. They're having a harder time going to use the restroom or taking showers or bathing because of their pain, their disability. They're having a hard time walking, their mobility. And conceptually, when we say someone's somaticizing, what they're doing is they're taking what's really an internal emotional experience, a psychological experience, and because of denial, because of avoidance, because of discomfort or lack of an understanding or nuance in that arena, they are then turning it into something concrete, something physical in a lot of ways. So you often see overlap and comorbidity with people who are suffering from, who would meet criteria for more traditional anxiety or mood disorders, who also meet the criteria for this. As I mentioned, there are some culturally related disorders. We've mentioned a couple of those already in earlier chapters. This is perhaps a bit of a stereotype, but I think it is a stereotype that holds up with some evidence. Classically, traditionally, we find that Asian cultures, compared to the West, tend to have more discomfort surrounding admitting mental health issues. And so, at least in Asian countries, it is probably more appropriate, more common for patients to somaticize and present to doctors with physiological symptoms. And even if they're symptoms of depression or anxiety, but they'll pick the ones that are physiological and what they call the vegetative symptoms of depression. So the person is more likely to go to the doctor and say, I can't sleep, or I have a bad appetite, or I just feel fatigued and lethargic all the time, as opposed to I'm sad, or I feel hopeless, or I'm thinking about, I don't want to be here anymore, I want to kill myself. So some of this is probably cultural, and in some ways what we have is these specific manifestations of the illness anxiety disorder that are sort of tied to specific cultures. So there's a concept called koro, which is present in some Asian cultures, of the genitals retracting into the abdomen, right? So that's the excessive fear, is this thing that, arguably, except in very, very rare conditions, does not happen. But it is nevertheless something that someone can kind of perseverate and obsess over. There's a common, I shouldn't say common, there's a phenomenon in Indian culture called dot, which is like sort of dizziness and fatigued, which is attributed to semen loss. So already we're talking about some things that are also probably wrapped up in concepts of masculinity. Another we'd mentioned before, which is kind of a very distinct subset amongst the Khmer culture in Cambodia, is Kielgu, which I'm sure I'm mispronouncing again. I apologize, which literally means wind overload. We mentioned this in a previous chapter, and this is the fear that the wind cannot circulate effectively through the body, and it tends to manifest itself through dizziness, weakness, fatigue, and trembling are seen as signs of this illness. So these are just cultural examples of how these things get defined within a specific culture, as opposed to the sort of more general diagnostic criteria set down in the DSM. So, what causes somatic symptom disorders? Um, we know that this is people that probably have, maybe dispositionally, perhaps through genetics or early learning experiences, um, they have an overreaction to physical signs and sensations. So whether it's through nature or nurture, which we'll talk about a little bit, the idea is that this person tends to have high reactivity to anything going on within their body. And I'm sure that, you yourself or someone is kind of like this. They start with an ache or pain, and it bothers them right away, as opposed to putting it in context or being patient to see if it resolves easily or if it doesn't get any worse. We don't know if it's isolated. We think it's got multiple causes. Okay, so the multidimensional perspective definitely plays in here. It's very unlikely that it's one isolated biological or psychological factor. It's probably a perfect storm of combinations of these factors that lead you to this extreme degree of a somatic symptom disorder. It may be something you've learned from family early in life. To focus your anxiety on physical sensations. So in a family, for example, where there's a lot of discomfort or discouragement from talking about feelings or emotions, but yet it's okay to talk about the fact that my stomach's upset, or I feel nauseated, or I feel really tired, or I'm in pain, or I can't sleep. Well, that person may learn that when I feel any of those things, I need to focus more on what's going on in my body, and sort of that's the way it's appropriate or okay to process these types of feelings. There are a few additional factors that we think contribute to the etiology of these disorders. I mentioned stressful life events. People with somatic symptom disorders, like the two we've discussed so far, tend to find that they get worse during times of stress. They may first emerge during a significant period of stress. If there was people in the family during childhood who were experiencing serious illness, a sibling, a parent, a grandparent in the home, then that is a risk factor, we believe, for developing this. And then there's also sort of the more subtle sociological aspects of possible etiology, which is that some people become attached to playing the role of the patient, or not even playing, but being in the role of the patient. We're going to talk about playing the role of the patient in a moment. But there are some benefits to being ill. But in most situations, there's sympathy, there's attention. In some cases, there's diminished expectations of what that person can be responsible for, and therefore it takes some stress off of them. So there's various ways in which it may be beneficial to be the sick person, so to speak, including attention. And so you might think about people who don't receive unconditional positive regard or love from family, but do get attention if they're actually sick. So it's like no one's paying attention to the fact that I seem sad or upset, but if I'm throwing up, or if I run a fever, or if I'm actually sick, then people are going to stop and take care of me and make sure I'm all right. So again, as is always the case, as your book's going to reiterate over and over, what we're seeing here is that we have to consider multiple possible causes that interact with one another, that may have reciprocal effects on one another, and that add up to reach some threshold to develop these disorders. This is figure 6.1 from your book. I don't know why this version of it manifests with the not for sale watermark there. But this is just one way of sort of conceptualizing how this process might happen. So you start with a trigger of some sort, information, an event, an actual illness or observation of an illness, an image of something. And then the person undergoes a perceived threat. And that leads them to feel apprehensive or anxious. You then see an increased focus on the body, some increased physiological arousal in a negative way, that checking behavior and seeking reassurance from others, and that starts the cycle of preoccupation with perceived abnormalities in the body, sensations, some sort of illness. And then, of course, when the person has legitimate signs and, from their own body, normal things like aches and pains or an odd sensation in the body, they misinterpret that bodily sensation, and that indicates something serious is wrong here. There's a little bit of overlap if you think about how we talked about panic attacks recently. Your physiological fight or flight system is triggered. For some people, they look around for the threat, and if it's not there, they don't really have that thought, oh my gosh, what's wrong with me? I'm going to die. Something bad's going to happen. People who are prone to panic attacks tend to misinterpret those symptoms, those signs from internally in their body. And the same is true in this type of disorder. The person is misinterpreting what might be a normal small amount of pain, or just a normal process like, for example, digestion. That feeling of peristalsis when the gut is moving around and digesting food. And that leads them again to perceive a threat, which leads to this circle of increased apprehension, and the same process repeats itself until it kind of becomes like a feedback loop. Limited treatment research, of course, because A, rare condition, B, newly specified diagnostic criteria. Same thing that happened we were talking about these types of disorders. So there's limited amounts of effective research. We do know that mild cases of sort of illness anxiety disorder, the early manifestations of this are less severe, less crippling cases, may benefit from CBT or cognitive behavioral therapy. Sometimes it's just a nature of educating the person and giving them the tools to understand what this symptom means, or perhaps what the likelihood is. If the person is convinced they have a rare neurological illness, helping them to understand, no, this is extremely rare and you've been ruled out. So some degree of reassurance from medical professionals and or psychologists for mild cases may be effective. There's also some exposure treatment that can effectively treat illness anxiety disorder. And so this would be somewhat similar to the type of treatments we use for PTSD and other types of anxiety, where the person has to sort of sit with the scary feeling and then learn how to decrease their anxiety response through relaxation or imagery, and sort of extinguish the connection between the anxiety and the belief that one has a serious illness, or that this symptom means something more serious than it does. There's some evidence that's limited, again, rare diseases, rare disorders. A small aside, there's a tendency to call all psychological disorders diseases. This really starts in the substance abuse world, where we started referring to alcoholism as a disease. I have mixed feelings about that term, so I apologize if I slip sometimes and call things a disease. I'm not really sure that that's an appropriate use of language. This is something you can debate. I try to stick to the word disorder if I can. So again, if I slip, I apologize. Back to the point, though, there's some limited evidence that antidepressants may be helpful for people that are undergoing these types of somatic symptom disorders. One way that we can sometimes treat it is to have a gatekeeper physician who's really assigned to limit excessive use of medical services. And let me explain what I mean by that. Is that a lot of people who have either of these disorders, the illness anxiety disorder or the somatic symptom disorder, they will often do what's called doctor shopping. So for example, let's take someone who has illness anxiety disorder and they are convinced that they have cancer. Well, they may go to a primary care physician who says, I don't think you have cancer, but if you insist, I'll send you to an oncologist. And they go to that oncologist. The oncologist, if they are willing to sort of humor the person, or if they think there's enough evidence just to be sure, they might order a PET scan or an MRI or do some imaging. And they may say, nope, you don't have it. Well, then the person, because of that firmly held excessive anxious feeling that they do have the disorder, they're going to develop it, the illness of cancer or whatever, will then go and say, well, they'll discount that doctor for one reason or another. And then they'll go seek another doctor and another doctor and another specialist. And so what happens is the left hand doesn't know what the right hand is doing. They may not tell the subsequent physician, oh, by the way, I already saw these other physicians, these other doctors, these other providers. Because they may want to dismiss these were not good doctors. Now I'm going to the good doctor kind of thing. Or B, they may know they're going to be told, I'm not going to repeat the same tests because they've already been conclusive. So as a result, they are often doctor shopping. They're going to lots and lots of different providers and undergoing lots of unnecessary tests. So one way to do this is to sort of assign what's called a gatekeeper physician. In many cases, this might be your primary care provider, sort of a generalist, who they make an agreement with the patient, or they establish their care in such a way, if it's within one healthcare system, that I'm going to be sort of the quarterback. I'm going to be the person that sort of is coordinating what's going on, and therefore they can help to reduce that doctor shopping excessive use of services. You can also do things like reducing the supportive consequences of illness. So as we mentioned about in possible causes, the increased attention and the increased care and sympathy that comes with someone who's saying, oh, I have cancer, I'm sure I have cancer, or I'm sure I have whatever. As a result, what you can do is work with that social support system, whether it's a spouse or parents or loved ones, friends, family, whatever, and encourage them to stop providing that attention, to try and reduce the consequence of that behavior that might be rewarding, that might be kind of keeping this thing alive. Traditionally, treatment of somatic symptom disorders really started with psychodynamic approaches, as did most everything in psychology. But the idea was very prominent in psychodynamic belief or theory that what was going on was there was a traumatic event, and that this was a projection, essentially. That the person was utilizing an unhealthy defense mechanism to deal with some trauma, and therefore it was manifesting. Now, in a lot of very early cases of Freud and Freud's immediate students, there was lots of discussion about hysteria. Now, hysteria was a condition that was prominent in the Victorian world amongst women. The truth of the matter is that hysteria was probably a manifestation of a number of things, but it was generally thought of as a condition that was almost always seen in women, where they would present with physiological symptoms when there was no underlying cause. So what we might now call illness anxiety disorder or somatic symptom disorder. Now, we know from a better understanding of culture and of the times that this was occurring in, that there was, generally speaking, less emphasis on women's health. There were less doctors that were properly trained to understand, women's bodies and what was going on with them, and things that might actually be legitimately happening that are being labeled as hysteria. More importantly, though, there was an idea that this was probably, in some situations, in some cases, a reaction to extreme misogyny, to dissatisfaction with opportunity in life, with other things like that. So more of a social, cultural disease in some ways. Nevertheless, the early Freudian research and writings are almost always tied up with the idea of hysteria, which is really kind of a Victorian era manifestation of a somatic symptom disorder. And that hung around for, as long as the psychodynamic approach was dominant. There's most likely what you're going to see is a cognitive behavioral approach to treating these types of disorders these days. You withdraw the reinforcement for the complaints regarding body symptoms. So whether you establish a gatekeeper physician that keeps the person from overusing medical services and therefore getting lots of attention and feedback, you talk to families and loved ones about how they should respond when the person brings up these issues of anxiety about their health. You can work with the individual in some cases, depending on how severe the case is. You can work with them to sort of recognize the distorted cognitions that are going on in their own, the sort of maladaptive thoughts that they're having about the potential risks of an illness, their body image, how they're interpreting internal signals. And you can utilize an ERP or an exposure and response prevention approach, sort of similar to what we see in OCD treatment. So we've talked about that in a previous chapter, but this idea of forcing the person to confront the thing they're fearful of, and then preventing them with their encouragement and their cooperation, of course, from doing the thing that is meant to assuage that anxiety, whether that's calling a doctor and making an appointment, going and getting a PET scan or something. As I said, there's some antidepressant medication evidence that seems to be helpful, and these are typically the same medications that are used to treat anxiety disorders. So things in the anxiolytic and some of the more modern antidepressant type medications that affect norepinephrine a lot of the time. So the third thing we're going to talk about, third sort of diagnosis that we're going to talk about is as I said, a larger catch-all called psychological factors affecting medical condition. This is a diagnostic label that's helpful for clinicians, medical providers, and what it's simply saying is there is some psychological underlying variable that is impacting a general medical issue. For example, someone who is having difficulty with concentration, either due to a psychological or physiological reason that makes it hard for them to take their medication on time, or to check their blood sugar, or to do whatever they need to do to be healthy. Another example is someone who is in denial about their diagnosis or the severity of their illness or their prognosis, and therefore fails to cooperate or comply with medical advice. Working in the medical field, it's interesting. We've tried to get away from the phrase or the word non-compliance. It's sort of paternalistic. It implies that you're not complying, you're not submitting to what medical professionals are telling you to do. Modern medicine tends to focus on being more cooperative and collaborative, where the patient is more centered in the process of developing a treatment plan. And so we've used the slightly softer language now we tend to use as non-adherence to the treatment plan, that kind of thing. Either way, some underlying psychological factor which is really affecting the person's ability to do what they need to do to manage a health condition of one form or another. Let's move on to the fourth diagnosis that we want to talk about in this section, which is conversion disorder. Conversion disorder is technically called conversion disorder, functional neurological symptom disorder. It's really rare, first and foremost, and somewhat unique. It's different. There's a lot of overlap between illness anxiety disorder and somatic symptom disorder. This is pretty distinct from those. Basically, there's some degree of altered motor or sensory function that is inconsistent with the neural or medical condition and not better explained by another disorder. This is somebody who is often presenting as if they have a neurological problem, whether it's a head injury, a brain tumor, a stroke, whatever, but no such problem is detected. It has to cause significant distress or impairment in the individual for it to be considered a disorder. But the idea is that the person is manifesting symptoms that are not really better captured. They tend to be neurological symptoms, and there is no evidence to support them. And this can be a variety of things. It can be paralysis, numbness, disability, lack of mobility. There's a phenomenon called psychogenic seizures that I'll talk about in a moment, where the person is having what look to the outside observer like serious, potentially grand mal seizures. However, if you happen to give them an EEG, no seizure activity at all. And what you notice is that these seizures tend to occur in times of psychological stress. So conversion disorder is called as such because from a psychodynamic perspective, the idea was the person is converting their psychological stress into physiological symptoms. Now, in some cases, the person might have a strange indifference in their attitude towards the symptom. So the kind of classic odd presentation is someone who says, I woke up yesterday morning and I cannot move my right arm at all. I can't do anything about it. But they're not worried about it or concerned. They present it very matter-of-factly. And in some cases, they're functioning otherwise, maybe mostly normal. What's unique and important to distinguish conversion disorder from a few other types of things we're going to talk about is the person is not deliberately faking the symptoms for the purpose of a concrete gain. That is what we call malingering. So malingering is when a person presents with an illness or a symptom of some sort for secondary gain, whether it's to be certified for disability and receive compensation, to avoid punishment. You see a lot of malingering in prison populations, in the military, in places where the person is trying to get out of something aversive they don't want to do. That is different than conversion disorder. That's kind of the fascinating thing about things like psychogenic seizures is it may seem like a deliberate childish attempt to avoid dealing with something, but when you dig under the surface, the person is not making a conscious decision to suddenly have psychogenic seizures. I've seen examples when I worked in a residential PTSD program in a VA in New Jersey. We had a former Marine from Vietnam who had a lot of trauma. He had been a Marine recon sniper, had a lot of trauma secondary to killing a lot of people in the line of duty. And he would start to talk about his trauma in group, and then all of a sudden would start having a seizure. And it would freak people out, and everyone in the class or in the group would jump up and help the person and gently get them to the ground or their chair. They get a lot of attention. And the person would swear up and down this was a real seizure. And I genuinely believe that he thought it was a real seizure. Of course, we worked him up medically. We sent him to neurology. We sent him to get imaging done. No evidence whatsoever that he's actually having seizures. And I don't think he was consciously doing this to avoid talking about painful things. Rather, he had created this maladaptive response in his mind that he was not necessarily aware of as being, A follows B or B follows A. It was not a connection that he was making between what I was talking about and having the seizure, but he certainly began to have an aversive response to the idea of talking about his trauma because he feared, I'm going to have another seizure. So the DSM-5 criteria for conversion disorder are one or more symptoms of altered motor or sensory functioning. What you often see is, I said, paralysis, seizures, numbness, other types of what look often like neurological symptoms, and that incompatibility between the symptom and the medically recognized condition. So, for example, psychogenic seizures, when people have seizures, there is a distinct pattern of brainwave activity that you can detect with an EEG. It looks distinct from every other state of arousal, wakefulness, sleeping, whatever. The same way that, during someone's normal sleep patterns, delta waves look very different than, sort of REM sleep. And so it's not better explained by any other medical condition. And of course, it causes the person significant distress, as is always the case with something that's a disorder. Conversion disorder is extremely rare. It tends to have what's called a chronic intermittent course. So it will come and go, but it is persistent over long periods of time. It's chronic in that sense. It is often comorbid with anxiety and mood disorders, or in the case of the example I was citing of the former Marine sniper who'd been in Vietnam, he certainly had PTSD. He certainly was depressed. Conversion disorder tends to be seen primarily in females. What Freud and his colleagues were calling hysteria in some cases was probably conversion disorder. It often has its onset in adolescence and is more common in some cultural and/or religious groups. This goes back to what I was talking about earlier about other types of somatic disorders, where this is my opinion, but there's certainly some research that holds this up, is the idea that cultures that have less comfort discussing emotional, psychological problems may subtly encourage individuals to manifest their stress, their pain, their suffering psychologically into physiological form. And so as a result, it is converted from a psychological stress or suffering or pain into some physiological symptom. It is not well understood because it is rare. As I said, the Freudian psychodynamic view is still somewhat common, although largely unsubstantiated by the research. There's probably, a little bit of smoke there, but not necessarily fire. But this idea that past trauma, unconscious conflict is quote unquote converted to a more acceptable manifestation, like pain or a physical symptom of some sort. But honestly, we don't have a good handle on the cause of conversion disorder. Let's talk about a couple possibilities though. Actually, before we do that, I want to show you this example of glove anesthesia. So this is one of those ways in which a neurologist or even a psychologist who's versed in this information, who knows physiology, can often differentiate between a real neurological condition and and someone who has potentially a conversion disorder. So you have a tendency of people to have something called glove anesthesia. And glove anesthesia is a type of conversion disorder where the person says, I cannot feel my hand at all. My hand is entirely numb. And so, of course, that can become very problematic where you're dropping things, you're burning yourself inadvertently, and that kind of thing. But when someone comes in and has this report, they will invariably, unless they're a physician, unless they've taken a class like this and they already know this, they will say, my entire hand is numb or tingling, or I'm experiencing neuropathic pain throughout my hand, that kind of thing. What we know is that the way that the body is wired in the nervous system, there is the ulnar, that's a hard word to say, ulnar nerve and the radial nerve. And those are two separate nerves that run, from the spinal column, spinal cord out into the extremities, into the hands in this case. And they are two separate pathways that affect the two sides of the arm, essentially. That's why they're called ulnar and radial, in reference to the two bones in the forearm that run, there's two bones that are separated in the forearm. So what we know is that if there was damage, nerve damage, if there had been a stroke, if there was neurological damage, peripheral nervous damage of some sort, what you would actually see would be something more like what you see on the right. It would be very common to have numbness or tingling in these two fingers or in these three fingers, okay? Because the way the nerves are set up, that the likelihood of having both with the exact same impairment is extremely low. So when someone comes in and says, my entire hand suddenly went numb and it won't go away, you want to start thinking differentially, as opposed to someone who comes in and says, I'm having numbness and tingling in these two fingers or these three fingers, or vice versa. That is more consistent with the actual nerve pathways. And so this is one way in which sometimes we start to have some suspicion about what's going on with a person. Is this physiological or is it psychological? So let's go back to some of the other causes of conversion disorder. I mentioned primary and secondary gains. Freud thought that the primary gain was avoidance. You escape from dealing with the conflict, and I tend to believe that there's some evidence there. Going back to my example of the Marine sniper, he, by virtue of his psychogenic seizures, and psychogenic just means psychological origin, caused by psychology, not physiological. He didn't have to finish the story that he was telling about his traumatic experience. Now, this was happening in trauma groups. Now, we use the term trauma group on that unit. It was a group that met twice a week, where the intent of that group, based on an exposure model, but also a peer support model, was to specifically talk about trauma. When you came to that group, the expectation was that when you were comfortable, you would have to talk about the things that had happened to you in combat. In this case, it was a combat PTSD unit. He never had psychogenic seizures in the classes about coping skills, in the psychoeducational material that didn't ask you to talk or address your trauma. He only really had them in the trauma group or in individual sessions when he was supposed to be talking about trauma. So he was escaping or avoiding the thing that was causing him, obviously, a lot of distress and a lot of psychological suffering. He also would get a lot of attention and sympathy in the room. All eyes would suddenly turn to, what's going on with this guy? Is he okay? Do we need to call 911 or call a code and get the team down here to get him to the ER? Because we were in a hospital at the time. But the idea is that not only is he avoiding, but he is suddenly getting a lot of attention and positive regard. So those are two possible primary, secondary gain aspects that might be a cause of conversion disorder. Sociocultural factors, as I said, more common in low SES, lower education individuals, and patients are likely to adopt symptoms with which they are already familiar. This is kind of the thing with the glove anesthesia, is that as people become more aware of it, maybe through research on the internet, whatever, they tend to adopt those symptoms. They don't present with things that have likely physiological causes because they have not been educated about those things. They're not aware of them. The average person does not know that there's a separation in the nerves that feed, the two parts of the hand. Neurologists know that, and psychologists that are studying conversion disorder, and students like yourselves. But the average person doesn't know that. So you tend to adopt symptoms that you understand, that you're familiar with, and so there's some sociocultural play there as well. So if the conversion disorder manifests itself after a trauma, like this gentleman that I'm describing as an example, who's having psychogenic seizures, the treatment is to treat the trauma, not to treat the conversion disorder. Okay. And I will say that over the course of his 45 days in that residential program, he had less seizures by the end of it. Because I think he was getting really good treatment for his PTSD. I don't think he ever fully necessarily engaged with it, but he did put some effort forth. And I remember that towards the end of his 45 days, he was able to talk more about trauma in group without having psychogenic seizures. So in a sense, what you were doing was you were treating the underlying cause rather than this sort of manifestation of another disorder that came from it. Remove sources of secondary gain. We certainly did this. This is what's called a group milieu. It's a term that describes the treatment is by its definition linked with the idea of a group, of not just being treated as an individual, but being treated with peers, and that peer support and connection to people with similar experiences is part of the treatment. So we would constantly be talking about the milieu and about how to best help one another. And one of the things we discussed very openly with the patient there, and in some cases individually with people that were responding too much to his psychogenic seizures, was for his own good, we need you to not raise the alarm, right? Don't respond as if this were a real seizure, except to make sure that he's safe. Obviously we're not going to let somebody fall and crack their head on the ground if we could help them and stop them. But ultimately, he wouldn't do that when he was having psychogenic seizures. If you noticed, he was always able to be safely to the ground. He was not fully losing control of his body and potentially hurting himself, falling the way that somebody that's having an actual grand mal seizure might. So we talked with the groups about, hey, this is the understanding of what's going on with this person with their consent. They've made it's okay to talk about it. We need everybody to make sure he's safe, but then we're going to get back to the group. We're going to allow him, maybe the nurse is going to come check on him, or he needs to leave the group even, which, can feed the avoidance, but we're not going to allow it to be a distraction to the extent that he's getting that secondary gain if we can. And then you reduce the consequences of talking about physical symptoms. You basically want the person to the supportive consequences. So, like I said, the alarms don't get raised. The whole team doesn't come running and pay close attention to you and give you lots of sympathy for a long time to see, are you okay, when we know that underlying it, there's not a real physiological danger. The last disorder in this section we're going to talk about is what's called factitious disorder. Factitious disorder is someone who is purposely faking physical symptoms. So this is the distinction from the other things we've discussed so far. This person is conscious of the fact that they are faking a physical symptom. They may actually induce the physical symptom. They may do something, take something, whatever, or just pretend to have them. So it can be either or. There are often not a lot of obvious external gains, but there is the benefit of being in the sick role and receiving sympathy. And that is really at the core of a factitious disorder, is the person is not doing this for material gain with any real concrete objective. What they're doing it for is they have a fixation on being the sick person, being the patient, so to speak. So sympathy may be a secondary gain. But this is distinguished from the concept I mentioned earlier of malingering. And malingering is someone who fakes the physical symptoms for the purposes of achieving something specific. So getting approved for disability to receive compensation, getting paid time off of work, avoiding military service, that kind of thing. So in this case, this is, I have 2 children, and so, my kids are not really that bad about this, but occasionally, I can't do my homework, my stomach really hurts, right? That's malingering. Okay. And we all do this to some degree at some point in our lives, I'm sure. But the factitious disorder is unique in some ways because there's not always an obvious subjective secondary gain like that outside of being perceived as sick, as being in that role, which is for one reason or another attractive to that individual. So the DSM-5 criteria for factitious disorder are falsification of physical or psychological signs or symptoms, right? So it's not always a physical disorder. It could be schizophrenia, for example. The person could be claiming to have hallucinations or delusions when they don't. The individual presents themselves as ill or injured in some way. And the deceptive behavior is evident in the absence of external rewards. So this is the distinction from malingering, and is not otherwise explained by some underlying medical condition. Okay. So again, we want to make sure there's not some more rational, concrete explanation for what's going on before we would jump to a diagnosis like factitious disorder. So this is when someone's doing it to themselves, right? But there is a phenomenon called a factitious disorder imposed on another. If you watch a lot of Law and Order SVU, I'm sure you've probably seen an episode about this. It's something that I think is just fascinating to people because it is very kind of odd and difficult to understand, but it's commonly known as Munchausen syndrome by proxy. So Munchausen syndrome is another classic term for factitious disorder. Munchausen syndrome by proxy is inducing the symptoms in another person. And this is typically seen in a caregiver, including parents, who induce symptoms in a dependent. That could be their child. It could be an individual with diminished capacity that they're caring for. And the purpose is to receive the attention or the sympathy that comes with it. You will often see people who have this condition who are looking for, they want to be perceived as martyrs. They want to be perceived as someone who is very heroic and selfless because they are caring for this individual that has such a horrible physical situation. And it's extremely upsetting when you see it because it is essentially abuse, usually abuse of someone who has diminished capacity to defend themselves, either by virtue of being a child, being elderly, and perhaps demented, or having a developmental disorder or mental retardation or something like this. And it can be extreme. You see examples of people who are poisoning their own children to bring them to the hospital and have a lot of attention focused on them. There's a movie, The Sixth Sense, which some of you may or may not have seen, the M. Night Shyamalan movie, where there's a mother who is maintaining that her daughter is ill and her daughter eventually dies. And then it turns out that she was putting poisonous chemicals into her daughter's food. The mom was getting a lot of attention because she had a sick child. So as you can imagine, for many people, when their children are legitimately ill, like for example with childhood cancers, pediatric cancers, we have so much sympathy and empathy for that parent, because whether we have our own children or not, there's that strong connection of caring for the people who can't defend themselves or are vulnerable, and we feel bad for that person, and we might heap a lot of praise on them, like, this must be really hard for you. You're such a great caregiver, that kind of thing. Excuse me. And so as a result, that person receives some attention and praise in many cases as a result of having that loved one that's ill. So let's move on now from the somatic symptom and related disorders to dissociative disorders. As I mentioned, I think that both of these sets of disorders are somewhat difficult to wrap our heads around, so to speak, if you've never experienced them. And dissociation is a concept that is somewhat general and can manifest itself in a lot of different ways. But ultimately what it means is to dissociate is to display a severe alteration or a detachment from reality. So in the process of being detached or altered in your connection to reality, it can affect your sense of identity, your memory, or your consciousness in some way. there are two related concepts we're going to talk about: depersonalization and derealization. So depersonalization is a distortion in your perception of one's body or experience, um, feeling like your own body isn't real. In some sense, the phrase we'll often hear is, I'm looking at myself from outside my body. So being disconnected from the body in some way that it's experienced. Um, Derealization is when you lose a sense of the external world. We sometimes use the term surreal to describe this. Someone will say, I know that I'm in this, I'm sitting here and I'm seeing these things in this room, but I feel like it's a dream, or it's just in my head, that it's a hallucination. That all of this is, the classic example, of course, from pop culture, which you may or may not be familiar with, is the idea of the Matrix, from the Matrix movies. We're about to have a fourth Matrix movie come out here soon, I think. But the idea is that, it goes back to, deeply researched and thought about philosophical concepts like Descartes. When Rene Descartes was trying to make a philosophical argument for the existence of reality, he posited, well, perhaps I'm just a brain in a jar somewhere, and there's an evil genius that's stimulating me, that is giving me these experiences that I think I'm having, but in reality, they're just a dream. And that's kind of the concept behind the Matrix, right? Is that we're all connected as human batteries to power, artificial intelligence. But ultimately, in both of these cases, you are having some distortion or disconnection from your sense of self, or from your sense of the world being real. And that's why these disorders are sometimes hard to wrap our head around, because, on the one hand, it's a pretty extreme manifestation of this thing. I'm going to talk in a couple slides about how we do experience these things along a continuum to a much lesser degree. And by thinking about those kind of everyday experiences of mild dissociation, we can get a better sense of what this is like for someone that's experiencing the full-blown disorders. So that dissociation, as I said, is the process in which different parts of an individual's identity, memories, perception, consciousness are separated from one another in some way. So an alteration in our sense of self and or reality. Okay, so that's the real core of what we mean when we say dissociation. So, for example, when we're faced with an extremely painful situation, we simply just want to escape. We want to get out of it. And sometimes people use alcohol, or they binge eat to escape problems. We're going to talk about in this chapter the most extreme form of escape used by people experiencing things that are traumatic, situations that are traumatic, or intolerable distress, and that is dissociation. For some of these examples, the person is undergoing something so horrific, so painful, so stressful, so difficult, that in some ways it kind of breaks that connection between reality and the sense of self, and so it is often seen in that context as an extreme reaction to extreme stress. So let's talk about some ways in which we do experience mild degrees of dissociation in our everyday life. And I'm not dismissing the fact that some of you may have, really dealt with more significant disorders of dissociation, but given how rare it is, I'm talking to a larger audience here who likely has not experienced those extreme examples we're going to describe here in a minute. But ever been in a conversation, perhaps when you're listening to this lecture, where you just suddenly miss a section, you kind of disconnect, and you realize that you haven't heard anything the person said for the last few minutes. Not being able to remember whether you've done something or you thought about doing something. Okay, did I pay that bill, or did I just think about it really hard and had every intention of paying it and I didn't actually pay it? Did I have that conversation with that person, or was I just, imagining it because it was something emotionally charged? Another one is, sometimes they used to call it highway hypnosis, and I'm sure many of you have experienced this if you drive, which is that you may be driving long distance, especially in monotonous settings on interstates where everything's nice and straight, where you suddenly kind of come to and you realize that you don't remember part of the drive you were doing. You just kind of, you zone out, so to speak, is the common parlance we might use. Talking to yourself when you're alone is kind of a form of dissociation, right? Not necessarily unhealthy, not necessarily a disorder, but the idea of, it is a disconnection a little bit from the sense of self and reality, because we can think our thoughts internally. We don't have to say them out loud, and we still hear them. There's lots of healthy reasons and adaptive reasons why we might talk to ourselves out loud when we're alone. But it is an example of a very mild kind of dissociation. Daydreaming is an example of dissociation where you're just kind of lost in your imagination as opposed to being present in the moment, or being extremely absorbed into a movie or a book or whatever, is one of these common ways in which we separate. And we have feeling, occasionally we may have some feelings that a part of our body is not our own, especially when we're injured. There's a weird sensation when you really hurt yourself. For those of you that unfortunately or not have experienced that, we talk about time slowing down, right, in an accident. That's an example of a mild dissociation. Someone I had a wreck on my bicycle about a year and a half ago, maybe a year ago, on the Huckleberry Trail, where I was coming around a curve downhill, and there was someone jogging in the middle, and I hesitated trying to avoid them. I hit both my brakes on my bike, front and back. Happened to be on a very mildly damp spot on the road, and bike just went out from under me, and I slid 20-25 feet. Fortunately, only once on the gravel or on the concrete, and then the rest was on grass. But in my experience of that accident, I feel like it was going extremely slowly. I could see myself heading towards a fence post that I was hoping I would stop before I hit it, and I did, fortunately. I also had a car accident when I was 17 years old where I hydroplaned into the back of somebody. And now granted, I did hydroplane a significant distance. I had no control over the vehicle, but I had time to realize I was hydroplaning. I downshifted because it was a stick that I was driving. I pumped my brakes. I pulled the emergency brake, and I braced for impact. Now, this all happened probably within 2 seconds, but to me, it felt like 5 minutes. And so that's another example of kind of common, more common dissociations that can happen, especially if you've hurt yourself. You might look down at a broken hand or a broken ankle, and it just feels like it's not part of your body in some way, mostly because your body's being flooded with endorphins, and that can change your perceptions of reality a little bit. There are 4 basic types of disorders that are outlined in the DSM-5 in the dissociative disorder section. Depersonalization / derealization disorder. So those two constructs are tied together in one disorder. The phenomenon of dissociative amnesia. Dissociative trance disorder, which is a relatively new diagnosis that was not captured in previous iterations of the DSM-4 in the same way. And dissociative identity disorder, which we'll talk about at the end, previously called multiple personality disorder. Dissociative identity disorder, or DID as it's often referred to, is, I would argue, by far the most controversial diagnosis in all of psychology, but we will get to that in just a second. So people with depersonalization, derealization disorder have recurrent episodes in which they feel like things are unreal as far as their own body or their surroundings is concerned. If you remember, we have mentioned this term, depersonalization, derealization. I know I have mentioned it in the lectures. I'm not sure if your book touches on it as much, as a symptom of a panic attack. Many people who are in the midst of a panic attack, the cognitive symptom, besides the idea that I'm going to die or I'm going to lose control, I'm going to quote unquote go crazy, whatever they are thinking, will often report they feel like their things are unreal. They're observing their body from outside of it, or suddenly everything seems entirely surreal or unreal. So in this disorder, the person is having recurrent episodes of that, where they have those sensations of one or both, depersonalization or derealization. This can't be something that happens once and it is isolated. For it to be the disorder, it has to become something that's frequent enough, recurrent enough, that it starts to dominate and interfere with life functioning. And you only diagnose this disorder if it is the primary problem, as I said, in the context of panic disorder, other types of anxiety, and certainly within PTSD. You see people reporting feelings of depersonalization, derealization. We diagnose someone with this disorder when they do not meet criteria or are not presenting with symptoms of those other disorders, when this is kind of the core component. It is relatively rare. Now, depersonalization, derealization in the context of other disorders is not that rare. I mean, it's, obviously it's not common, but I have plenty of patients with PTSD who report some degree of dissociation, including amnesia, traumatic amnesia for certain aspects of their trauma. It's very common with trauma especially. but it's pretty rare for someone is only presenting with essentially depersonalization, derealization, and that's what's causing them the distress or impairing their functioning. So as I said, persistent recurrent experiences of these, one or the other or both, reality testing is intact. Now this is an important distinction. This is someone who is not delusional. They are not suffering from schizophrenia or any other psychosis. They know that the feeling is wrong, but nevertheless they feel that way. It is not that my consciousness is actually floating above my body, observing. It's not that I'm disconnected, my spirit, so to speak, is disconnected from my body. If I genuinely believe that, we are talking much more about something like a delusion, something like a psychosis. People with depersonalization, derealization disorder know that the feeling that they're having does not accurately reflect reality, but nevertheless they're experiencing it. And it does cause significant distress for it to be called a disorder. Obviously, depersonalization, derealization is quite common in the context of substance use or abuse. Not just with hallucinogens, of course, which, one of the core components of what hallucinogens do is to give people a sense of depersonalization, derealization. So that's certainly you have to rule out. But people can experience this through alcohol intoxication, methamphetamine, cocaine, other drugs as well. And not better explained otherwise because, people can have brain tumors that cause them to have senses of depersonalization, derealization. They can be in the middle of a delirium because they have an infection or they're septic and feel this way. And certainly within the context of schizophrenia, PTSD, panic disorder, that kind of thing. So as is usually the case, you don't make the diagnosis if it's not better explained by something else, either another psychological disorder or something physiologically going on or a substance that's in their body. So there are some other features associated with this disorder. The people will often show some cognitive deficits related to these episodes, short-term memory, spatial reasoning. They tend to be easily distractible. People who manifest this condition, they may have difficulty absorbing new information, and they may have reduced emotional response to things, be kind of numb or disconnected, and they may have dysregulation of the HPA axis in the brain we discussed that's associated with anxiety, the activation system. So, it's very likely that this person has a larger pattern or gestalt of how their brain functions, where it's easier for them to get disconnected from things they are focusing on, to be easily distracted, or have difficulty integrating new information or a new sense of self or a new sense of the world around them because of major changes that are, circumstantial. So there's probably some tendencies that lead a person to be more prone to developing this type of disorder. It's part of a larger pattern in their thinking. So this is the dissociative experiences scale from your book. It's adapted from a study in the Journal of Clinical Psychiatry, where you talk about specific symptoms and you can actually add up a person's ratings on this scale to determine the degree of depersonalization, derealization. It can be used as a diagnostic measure to try and get a sense as to whether or not they would meet criteria. And this is going from least common to most common. So the idea what you're seeing here is at the very bottom we have things like talking out loud to oneself when alone, acting so differently, feeling like two different people, do usually difficult things with ease or spontaneity, can't remember if you just did something or thought about it, staring off into space, unaware of time, finding familiar places strange and unfamiliar, not hearing part of a conversation, a body does not feel like it belongs to you, looking at the world through a fog, and the surroundings seem unreal. So these are all experiences that we have that are related. So it's arranged in descending frequency. So going from the top to the bottom, the top is more common, the bottom is less common. And the mean is just the score that people tend to have on this scale. And so as you can see, less common as you go down. So derealization, depersonalization is extremely rare. as are most of the disorders that were talked about in this chapter. It does have, like some of the other disorders we talked about, it's got high comorbidity with anxiety and mood disorders. It's 1 to 3% of the population is probably a very maybe even a generous estimate of the prevalence rate. But the onset tends to occur in adolescence, and as I mentioned in a previous slide, it's probably related to the way the person generally kind of relates to the world. There's probably a larger pattern in thinking that makes one prone to this type of disorder. It tends to run a lifelong chronic course, and we do know that people that have been through traumatic events of various types are much more likely to manifest feelings of depersonalization, derealization, or meet the criteria for the disorder. So having trauma in your past, whether it's combat or assault or natural disaster, any of those things, accidents, they can certainly increase the likelihood that you'll develop this disorder down the road. Because it's so rare, and because it is a very difficult disorder to kind of get a handle on, research is very scarce. There's really not a lot of systematic research on psychological treatments for this disorder. Some attempts to utilize traditional medications like antidepressants, like Prozac, this SSRIs, have showed no effect compared to placebo. So there doesn't seem to be a real significant impact from antidepressant medication to help with this type of disorder. A lot of times, as was the case with some of the things we were talking about in the previous section, treating the underlying condition like PTSD, anxiety, depression is the way of trying to reduce this symptom and to get the person less distressed and improve functioning. Another dissociative disorder I want to talk about is dissociative amnesia. There's lots of different types of what's called psychogenic memory loss. Now, that psychogenic is meant to differentiate this from what's physiological memory loss, which can happen from head injury, can happen from brain tumor, any kind of insult to the brain, physiological insult to the brain can cause amnesia of various types. Now, the classic kind of ridiculous trope from television and movies where you're hit on the head and you forget who you are is pretty unrealistic, but there are certainly people that undergo a traumatic brain injury that develop various types of amnesia. You certainly, if you've ever been under anesthetic for, general anesthetic for a procedure, you're familiar with a physiological memory loss, propofol, which is the medication that anesthesiologists use a lot these days for things like surgery. So if you've ever had, for example, I had my gallbladder out a couple years ago and had no memory of an hour before and an hour after the surgery at all. And it's very common with those types of drugs. But essentially, psychogenic memory loss is that which is caused by a psychological cause. So there are very different types. There's generalized amnesia, which is the inability to recall anything, including your own identity. And this is kind of the classic, movie or television trope of amnesia, which is I don't know who I am and I have no idea how I got here. I don't know anything about my family, that kind of thing. Localized or selective amnesia is more common, but albeit, these are both rare. And this is where you can't recall specific events. And in some cases, dissociative amnesia occurs in the context of trauma. So we actually utilize the term sometimes traumatic amnesia and PTSD. I have several patients over the years who have been in combat situations, key traumas, where they don't remember aspects of the trauma. They may remember the event itself, but they can't remember anything for several hours afterwards. They may have a retrograde amnesia where they forget the events that led up to the traumatic event, or they may even forget the traumatic event itself despite manifesting symptoms of PTSD. The sort of general layperson's understanding of this is that it's the way that your brain is trying to protect you essentially from something horrific. But the idea is that it is essentially doesn't have a physiological cause and can be in reaction to trauma. There can be another phenomenon, which is a really interesting thing. It used to have its own diagnosis within the DSM-4, and now it's captured under the heading of dissociative amnesia, which is called dissociative fugue, and I will talk about that in a moment. And this is where the person may travel or wander and may even go as far after extended periods of amnesia, assume a new identity in a different place. We'll talk about dissociative fugue in a moment. But essentially the person has no memory. They may come to suddenly and recover memory and have no idea how they got to where they are, ended up in that place. Um, the example that your book talks about a little bit, and it's certainly one of the biggest examples in pop culture about dissociative amnesia, is a book and then subsequently a movie called The Three Faces of Eve. So this is a movie that came out in 1957, and it was one of the it was a CinemaScope film, right? It was this new aspect ratio thing. But the book was very popular, and the book was written by two psychiatrists who had treated Chris Costner Sizemore, and she was also known as Eve White, which was the pseudonym they created for her. And they suggested that Eve had dissociative identity disorder, which was known as multiple personality at the time, and it really brought a lot of the idea of dissociative fugue and dissociative amnesia into the public consciousness. And it wasn't revealed to the public until 1977 who this person actually was, with their consent. So their identity was concealed, but it was very popular, and it got a lot of people thinking about dissociative disorders in the general public that never really paid attention to it outside of that trope. And if you think about it, in a lot of movies and TV, it became even sometimes a comical thing to have someone get bonked on the head and lose their memory. And much of this is really the byproduct of the popularity of the Three Faces of Eve. So this is the actual DSM-5 criteria for dissociative amnesia. Again, I apologize for the small print, but I want to capture this in one slide. It's first and foremost, it's an inability to recall important autobiographical personal information, usually traumatic or stressful nature. It's inconsistent with ordinary forgetting. This is not just being forgetful or not being able to remember a few small aspects of an experience. It most often consists of a localized selective amnesia for a specific event or events. In some cases, we do see that generalized manifestation where the person can completely forget their identity, life history kind of thing. Obviously, the symptoms cause significant distress or impairment in the person in their functioning. It's not attributable to the physiological effects of a substance or a drug. Obviously, the concept of blacking out while drinking heavy amounts of alcohol is an example of amnesia, but is not, not psychogenic in source. It's caused by the alcohol itself, the level of intoxication, or certain medications. As I mentioned, anesthetic can definitely produce amnesias. There are some neurological disorders, partial complex seizures, transient global amnesia, closed head injury, TBI, other neurological conditions that can cause amnesia. So you have to rule those out before diagnosing someone with dissociative amnesia. And then they mention that, again, you want the diagnosis that best captures the individual and their presentation. So you don't diagnose someone with dissociative amnesia if it's better explained by the fact that they meet the full criteria, for example, for DID, which we're going to discuss in a moment. If they have PTSD or the less severe version acute stress disorder, if they have a somatic symptom disorder or a major or mild neurocognitive disorder, aka a dementia. There's certainly a degree of amnesia that can happen with dementia. So you want to rule out these other diagnoses that might better capture what's going on with the person, this disturbance in memory, as opposed to diagnosing dissociative amnesia. Once you rule those things out and the person still presents with these symptoms, then we would go ahead and call it dissociative amnesia. As I mentioned, you can specify whether or not it occurs with or without dissociative fugue, which is apparently purposeful travel or bewildered wandering that is associated with amnesia for identity or for other important autobiographical information. And we're going to talk about that on the next slide. So dissociative fugue is pretty fascinating because it's so alien to the way we typically think about our sense of self and the way our memories work. And so sometimes people who are undergoing a dissociative amnesia will engage in what's called a fugue state or a dissociative fugue. Travel can range from brief trips to all the way across the country or the planet. It's usually this unobtrusive wandering over long periods of time and great distances. The person who's in the midst of a fugue state, interestingly enough, does not necessarily appear confused or impaired. They don't attract a lot of attention. They can be very purposeful and deliberate in the sense of, they may be the one, renting a car and buying a plane ticket or a train ticket, and it's really fascinating that the person can be absent in a certain sense from their sense of self, can be dissociated, but yet can be very purposeful and organized in their thinking and behavior in that sense. It appears to increase during highly stressful times. People are more prone to engage in a dissociative fugue, say, immediately after a trauma or a very stressful event. It usually, like I said, involves leaving an unpleasant or unacceptable situation. So the person finds themselves in circumstances that are very difficult to stomach or deal with, and therefore they just, they disconnect and leave. And recovery from dissociative fugue is typically abrupt and complete. The person just kind of snaps out of it and suddenly says, like the Talking Heads song, this is not my beautiful house, this is not my beautiful wife. This idea of being entirely taken aback by your setting. People in some cases who've had extended dissociative fugues have, started new relationships, new jobs, rented apartments, or bought homes, all kinds of incredible stuff that can happen as a result of this. But ultimately, the idea is that the person will often recover very abruptly and have complete recovery of their sense of self. So, dissociative amnesia and fugue, prevalence rates of 2 to 7% is, I think, a very generous estimate. This probably includes every degree of even, limited degrees of or localized amnesias that are secondary to things like PTSD and other conditions. The full-blown sort of, extreme example of a fugue state or general dissociative amnesia is much less common. It rarely appears in childhood or late adulthood. It's usually somewhere in sort of early to middle adulthood. It tends to have a rapid onset and then dissipates. Very little known about the cause outside of the fact that trauma and stress can serve as triggers. So most people recover and remember without any treatment. In many cases, they are obviously unaware they're in a fugue state until they come out of it, but there may be, loved ones or people that are looking for them that find them who confront them, and that's when they first become aware of the fact that they are undergoing some sort of amnesia. But as it says, most of them recover without any specific treatment for it. Another type of dissociative disorder is what's called dissociative trance. It has a presentation across cultures. In Nigeria, there's a phenomenon called Vinvusa. In Thailand, it's called Fipob. I hope I'm pronouncing that right again. This is where the person has dissociative symptoms and sudden changes in personality. Culturally, traditionally, the change may be attributed to possession by an evil spirit or something like that. What's interesting about this one is that there are some cultural traditions where trance is considered part of a belief system, part of a religious system, or a spiritual practice. And again, we come back to this idea that just because something seems odd or unusual to us in our culture doesn't necessarily mean that it constitutes a disorder. It may be considered perfectly normal within that context and does not cause the person distress, doesn't necessarily impair with their function, mess with their functioning, and therefore doesn't really constitute a disorder. So we always have to consider the context. And dissociative trance, again, very little known about it outside of these sort of cultural manifestations, and is quite rare. So finally, let's talk about dissociative identity disorder, aka multiple personality disorder is what it was formerly known as. As I said, I think you'd be hard pressed to think of a diagnosis in psychology that is more controversial, that is less well defined or understood than DID. Essentially, the defining feature is a dissociation or a fracturing of the personality, of the sense of self, into multiple personalities, which hence the name, multiple personality disorder. The individual will adopt several new identities, and typically it's not just one other identity. It is very frequently several identities. The average in the very small number of cases that we can actually measure is about 15, and there are some cases of people reporting as many as 100 of these unique personalities. The identities tend to display unique behaviors, voices, postures. This is sort of what's really kind of disconcerting or distressing when you see it for a lot of people, is that it is such a dramatic shift in presentation. As I said, extremely rare. I have never personally met a patient in my practice. Now, my practice might not lend itself to these types of patients. Those of my peers that work like in borderline personality disorder are probably much more likely to see this, but it is rare, and I've never seen a case of it. I think I've had one or two patients who have indicated it or reported it, who subsequently turned out to probably be on the antisocial personality, psychopath sort of spectrum more than anything, and it was simply a way of trying to divert responsibility from things they had done. And we'll talk about that in a moment as well, sort of the controversy. But ultimately, the person is reporting a splintering of their sense of self into separate individuals, so to speak. These are the diagnostic criteria from the DSM-5. So I'll go through these, but it's a disruption of identity characterized by two or more distinct personality states, often much more than two. It may be described in some cultures as an experience of possession. That's sort of how it fits into our older supernatural tradition of understanding this. There's a marked discontinuity in the sense of self, the sense of agency, and it's accompanied by these changes in affect. And remember, affect is how you present, how you look, your eye contact, your facial expression, your body language, your behavior, your consciousness, your memory, your perception, your cognition, and or your sensory motor functioning. These signs and symptoms may be observed by others or reported by the individual. As a result of these shifts from one personality to the other, people who have been diagnosed with DID will frequently report that they lose time. They have these gaps in their memory of everyday events, important personal information, or traumatic events that are inconsistent with just ordinary forgetting. What the presumption is, what's going on is that while the dominant personality, what we know as the person prior to this split, is not present, in a way. That's the way it's presented. So while the other personality is sort of in control, so to speak, they are removed from consciousness, and therefore they quote unquote lose time. While they are not the dominant personality, they're not experiencing the things based upon the conception of this disorder. Obviously, these symptoms have to cause clinically significant distress or impairment and must affect functioning. It's not part of a larger accepted cultural or religious practice. So that's another issue I wanted to point out, was in some cultures, these concepts are part of spiritual and religious beliefs and are not considered disordered. And honestly, because they're seen in context and they're accepted by other members of that culture, don't necessarily cause distress or affect functioning. In children, of course, we do see people doing this type of play where they will pretend to be someone else, or they'll have imaginary playmates, other types of fantasy play. We want to make sure that we're not confusing those relatively normal developmental things that children do with dissociative identity disorder. And the symptoms are not attributed to something else. Most likely, most obviously, blackout or chaotic behavior due to intoxication with alcohol or other drugs. There are, as I mentioned, some physiological things that can kind of cause this presentation in a similar way, like complex partial seizures. Complex partial seizures, unlike when you think about a quote-unquote seizure, a lot of people are imagining a grand mal seizure, a massive physiological response with violent shaking and a lack of awareness, and it's really tied to essentially an electrical storm in the functioning of the neurological system. Complex partial seizures can be where a person looks relatively normal, but their EEG shows something very distinct. And so people who are having complex partial seizures may, quote unquote, lose time, maybe absent. When you start talking to them, can just all of a sudden they're gone. They're not paying attention, and they can't be brought back to focus right away. So you have to rule out some neurological causes before you would consider this diagnosis. So what's unique about DID, as I said, is this idea of the alters, ALTER, the different identities or personalities themselves. People will refer to them, at least in the research, as the alters. That's the term they use for the different personalities or that are part of the fracture. The host is the identity that keeps the other identities together, typically the identity the person has had prior to the split. And the switch or the split is the quick transition from one personality to another. So these are all kind of unique to DID. You don't really see any of these concepts in other disorders. There's a lot of controversy about DID. Most importantly, whether or not it is a real thing at all. I think that the fact that it is included in the DSM-5 and previous versions is enough to give it some scientific credence. There's enough evidence available that there are some individuals that are experiencing a real phenomenon that we call DID. But there are plenty of examples of people faking DID for a variety of reasons. So some patients who present with DID, consciously or unconsciously, may be faking for a variety of reasons. So first of all, this is the really controversial part. The power of suggestion of therapists is a major discussion that's been had. Some people believe that DID is what's called iatrogenic, which literally means caused by a physician. So it's an unintended consequence of the therapist or the doctor using subtle techniques to suggest, sometimes sometimes through hypnosis, to suggest that perhaps the person has a separate identity. And so as a result, it's sort of like a confirmation bias. You plant that idea for one reason or another to that individual. That idea is attractive, and they may not even consciously be aware that they're doing this, but then they will then manifest those symptoms. So the idea is that it is caused, in a sense, by certain types of questioning, certain types of suggestion by people in authority positions like psychologists and physicians and psychiatrists. We do know that some people with DID are not faking, which is the reason why it's included in the DSM. There's a fair amount of evidence to support the idea that there are real changes going on in brain functioning when the person is switching between alters. Now, you might say that, a person who's really faking it well, who's a very gifted, talented sociopath, for example, or psychopath, I should say, can fake DID very effectively. These are people that are very good actors, people that are very good at taking on different accents, different mannerisms, that are consciously doing this. But we do know there are some people who claim to have DID, and you can examine their EEG during a switch and you see different types of brain waves, which one would imagine will be pretty hard to fake. So the conventional wisdom amongst the APA and amongst psychologists is that some people genuinely do have DID. We just don't know what proportion of those people that are diagnosed with it or who present with it actually have it, and which people are either faking it or are essentially having it projected onto them by the diagnostician, and that can be a real problem. So let's talk a little bit about that in more detail. So it's hard to separate the faking from the real. There are no really reliable diagnostic methods that exist. Checking EEG is one thing. There's some evidence for that, but that's not really practical a lot of times. And as I said, some people believe that the disorder is iatrogenic, that it is caused, unintended consequences being the case, but that it can be caused by the actions of the therapist, such as suggestion and hypnosis. So one really powerful example of this is the story of Sybil, and it's becoming less likely because, as time goes on, this has been lost from sort of popular culture, but you may hear references to Sybil, and this is what is going on. So Sybil, aka Shirley Ardell Mason, was born in 1923. She died in 1998. She was an American art teacher, and she was reputed to have DID. In that time, they were calling it multiple personality disorder, and her life was described with some adaptations to protect her anonymity in a book in 1973 that was very, very popular. It was subtitled "The True Story of a Woman Possessed by 16 Separate Personalities." So you can already hear a little bit of the sensationalism in the title. There were 2 films made, both of which were pretty popular, one in 1976, and then there was subsequently another made in 2007. And both the book and the films used the names Sybil Isabel Dorset to protect Mason's identity. And her treatment under 2 psychiatrists, specifically under Cornelia Wilbur, have been criticized with allegations that Wilbur either manipulated or just simply misdiagnosed Mason. She subsequently wrote a letter to Dr. Wilbur a few years later admitting that her alters were fake. So in Sybil's case, we do know that she later admitted that she was simply going along with the line of questioning that was being presented by the psychiatrist because it was convenient and because it made her very interesting, and it garnered a lot of secondary gain, a lot of attention. Nevertheless, by then, Sybil's story was, firmly entrenched in popular culture, and it became something that was known about by a lot more people, and therefore was available for lack of a better term, for psychopaths to take advantage of. The most obvious example of this is Kenneth Bianchi. Kenneth Bianchi was also known as the Hillside Strangler and is a very famous serial killer in Los Angeles. He raped and murdered at least 10 women, and he would leave their naked bodies on the side of the hills outside of Los Angeles, and therefore was called the Hillside Strangler. And he invariably, he killed his victims in a number of ways, but many of them were strangled. He claimed to have no recollection of the murders. So even though there was plenty of forensic evidence tying him to the murders, he claimed to have no evidence of it. And the defense attorneys saw an opportunity and brought in a clinical psychologist who then hypnotized Kenneth Bianchi and asked him if there was some other part of Ken that he could speak with. Of course, that's the iatrogenic suggestion right there, right? You're crossing a line by presenting the opportunity, by presenting an excuse or an explanation without the patient initially starting that presentation. He simply said, "I don't remember." He never said, "I'm someone else," there's someone else who did it. The defense simply saw an opportunity of a possible insanity defense to save Kenneth Bianchi's life from the death penalty. And when the psychologist hypnotized Mr. Bianchi and asked him if there was some part of Ken he could speak with, Steve appeared. Okay, so Steve was the alter, in quotes here, that Kenneth Bianchi created. And the prosecution then brought in an expert who conducted a lot of personality tests and suggested, a third personality. And so there was really no independent verification ever, but by all accounts and by subsequent interviews and things, the assumption is Kenneth Bianchi was simply doing what psychopaths do, which is lying and manipulating when they're caught, when there's actual consequences for their behavior. So nevertheless, the idea that the Hillside Strangler had DID there's psychology textbooks that still make that claim, and became part of the understanding of that story as well. So we know that it's extremely rare. Again, 1 to 2%, I would argue, is probably a little bit exaggerated. It is more common in females, but this is one of those disorders that we have to be very careful about sort of gender bias in diagnosing. Onset is almost always in childhood or adolescence. It has a very high comorbidity rate with other psychological disorders. It is more commonly reported in people that have been through sexual abuse and other types of trauma in childhood. So the classic presentation of DID, if you ever were to come across it as a clinician, the most likely presentation you're going to hear is that someone was being chronically sexually abused, either sometimes a singular event, but often repeated sexual abuse. And they theorized that they created an alter, a separate personality who would then undergo the trauma. In some cases, people will say, well, I'm so-and-so, and I created this other personality who can handle the assault, who is tougher than I am, who's more resilient, who doesn't give a crap, for lack of a better term, who can put up with horrible things. And so that creates that initial schism of the separate personality. And then when the individual sees that in some way this sort of, I wouldn't call it a technique because I don't think it's that deliberate, but that this splitting of the personality is in a sense adaptive, at least in the moment, they then utilize or engage with that technique in other various ways and create multiple alters to deal with other types of situations or stresses in their life. It tends to follow a very lifelong and chronic course, but again, we have a very small data set we're working with and very limited good empirical evidence. So we don't know what causes it, as I said, but it is very, there's a really good chance that it's associated, we know it is associated with severe chronic trauma, often abuse in childhood. And the level of social support that that child or individual has is also an indicator. The risk increases if there's not good social support after the trauma. So the idea is that the dissociation, as I mentioned, is an attempt to escape. It's an opportunity to escape the impact of the trauma. It didn't happen to me, it happened to my other personality. And that's a way of, again, avoiding escaping something horrific. And I don't want to I don't want to victim blame, obviously, and I'm not saying this person is, this is not malingering. This is not, and with people that we believe genuinely have DID, we're not saying this is a deliberate, sort of, what's the word I'm looking for? Disingenuine thing. This is simply when you put people under horrific levels of stress and trauma, they will go to great lengths to try and protect themselves in various ways. And that seems to be what's going on. And as I said, closely related to PTSD, and might be sort of an extreme subtype of PTSD. It's very rare as DID is, it's very rare to have someone present with DID who has not also undergone trauma. So it might be considered as some subtype of PTSD or some particular maladaptive attempt to deal with PTSD. There may be some biological vulnerability, but we don't really know. There might be some dispositional tendency to dissociate in general. And then if you combine that diathesis with the intense stress of abuse or of trauma, especially chronic repeated trauma, then you see this manifestation. But we do know that most of the risk for DID is really related to extreme environmental stressors. So treatment of DID is about as controversial as the condition itself. But basically the idea is to is to help this person who was lacking in the ability to cope with recurrent trauma in many cases, to somehow reintegrate the identity, to try and bring the various personalities back into one cohesive whole. And so that's really the kind of the overarching goal of treating DID. You want to identify and neutralize the cues and the triggers that tend to provoke the memories of the trauma and therefore the dissociation. So what will happen is, if you follow this chain of logic, the person undergoes this trauma, they create the alter, at least the first alter, to be the one that receives the trauma to protect themselves, the host identity from the trauma. But then when they subsequently are requested that they talk about the trauma, or they're reminded of it in some way by a trigger in the environment, they then tend to dissociate again, right? Because it's this worked for me in this horrific moment. When I'm reminded of the horrific moment, I'm going to engage the same tool. So as part of that, of course, the person may have to relive and confront the earlier trauma through an exposure treatment, and it becomes very challenging to help an individual who's undergoing exposure treatment to not rely on that dissociation as a way of avoiding, trying to help them to stay present in their personality during the exposure treatment. There's some evidence of hypnosis being used effectively, but I would argue that hypnosis is slowly but surely losing a lot of use. It's not as common as it used to be in psychology. It's become something somewhat antiquated, although there are some people that still do utilize hypnosis for a few things and show some empirical evidence for its validity, but you're more likely to see it in people that are treating DID, I think. So this is tied to the idea of false memories because, as I mentioned, some people believe that some cases of DID are iatrogenic. They're caused by various providers, medical and psychological providers. So it is possible to create false memories of abuse by the power of suggestion. And there was sort of a lot of attention paid to this in recent years of psychologists who seem, or psychiatrists in some cases, other types of therapists who seem to be suddenly detecting lots and lots of patients with false memories, and that should be your first red flag because it is relatively rare. I'm sorry, not detecting lots of people with false memories, but lots of people detecting recovered memories, what they were calling recovered memories. And for many people, I think this becomes an attractive pull for them to continue doing so because makes you somewhat unique amongst mental health providers if you have this gift, so to speak, quote unquote, of helping people to uncover these recovered memories. The problem is that in many cases the evidence supports the idea that it is a consequence of it's iatrogenic. It's a consequence of the way that things are being suggested to the individual and the way the questioning is presented. So some patients may think they have repressed memories of abuse, which are later shown to be false. But of course, the impact of that is often it's too late. If you're going to accuse someone of sexually assaulting you, who based entirely upon a false memory, as you can imagine, there's a lot of negative impact for everyone involved in that. So the basic conclusion is that therapists of all various types need to be very careful not to suggest an untrue history by mistake. We need to be well trained in how memory functions, and the idea, like based upon the research of someone like Elizabeth Loftus, that memory is malleable and it can be affected through in intentional and unintentional subtle ways. Just a line of questioning alone that may seem sort of naive and harmless can actually plant this seed in a way that can be quite damaging for both the patient and for those around them. So we need to be very careful about how we ask questions about memories in the past, and that we're not suggesting things that then the patient will latch onto that could have a really negative impact for them and those around them. So I'd like to summarize a little bit about these two classes of disorders and talk at first about some of the things that make them hang together a little bit, perhaps why they're in a chapter together, besides just convenience. Both these types of conditions are very rare. And I think that, as I mentioned earlier, I think that we have a hard time, the average person who has not had these types of experiences or manifested these symptoms to this degree, have a hard time relating to or understanding them. As I mentioned, there are some examples of how we all along a continuum may experience things like dissociation or some degree of somatization. We're facing something. We have a big exam coming up, and we start feeling nauseated in our stomach. So we're somaticizing our psychological stress into a physical symptom. We may develop a headache because we're worried or stressed about something. But it is hard for some people, or many of us, to understand the full extent of these disorders, and that makes them, for lack of a better term, they're perceived as odd, they're perceived as eccentric, and they are, in many cases like DID, very extreme. But ultimately, the basic premise is, in the somatic symptom disorders and the related disorders, you've got physical symptoms without a clear medical cause that seem to be caused psychologically. It might be psychogenic in nature, if you would can use that term. And then, of course, the dissociative disorders are really associated with pretty extreme distortions in how we perceive reality, in our memory, and our sense of self. Because they are rare and because they are controversial in a variety of ways, we don't have a lot of well-established treatments. A lot of the research is generally lacking. Now, part of that is just the rarity. It's hard to get subjects to do good large-scale experimental research because you can't get enough people to draw any decent conclusions based upon the way that empiricism works. But I also think, as I said, because they're rare, there's not a lot of attention paid to them, and therefore not a lot of funding provided, and not as much interest, not as much return of potential good for society as a whole, because they affect so few people. But the end result is that they are disorders that we don't know as much about as we do the more common disorders. But I think, for those of you that are considering, a future in clinical psychology, it is very important to be aware of them and to be knowledgeable, because sometimes these things do come across your desk, and you do interact with patients where having this frame of understanding and having an accurate diagnosis can at the very least be helpful for you and the patient to make sense of their case, to conceptualize what's going on. Even if it doesn't lead you to a empirically validated good treatment, it may allow the patient to have something to hang their hat on to explain these odd experiences that they're having. And it may indicate which courses are likely to help and which are unlikely to help. So there is a benefit to being aware of them. And of course, further investigation and further research is really beneficial.